Welcome, everyone. These are my disclosures. I want to thank the organizers for this invitation. I'm honored to be here with my esteemed colleagues. Today, I'm going to be talking about how to build a vascular practice in today's competitive environment. But before I do that, I wanted to give you a little bit of my background so you can understand why I talk about this and other things related to vascular disease and why I think I have a good background and skill set to do this. I did my fellowship back in 1999 at Miami Cardiac and Vascular Institute and then stayed on as an attending for another year. And I'm also fellowship trained in neurostroke from UCLA. I was in private practice for about 16 years, at which point I was asked to come to the University of Miami and build a vascular practice where they really had none. I think it had been almost 2 decades since they had done any type of peripheral arterial intervention. And so I had a tough task on my hand, as you can imagine. As many of you may or may not know, my passion is really educating and training the next generation of physicians. There's really been a rapid explosion of innovation and information, not only in healthcare, but specifically in vascular disease. And it's really difficult for many to keep up with the latest news, techniques, and products available, especially if you're not in that environment. And that's part of the reason why I started my YouTube channel, Dr. Tamala's Vascular Channel, because I wanted to teach and give physicians the necessary background and technical skills needed to treat patients not only safely, but with expertise. So what kinds of things will you see if you come and check out this channel? Well, you're not only going to see CTOs and angiograms from head to toe, but I'm also going to show you things like what is Navi bossing? What is the knuckle wire technique? What does a subintimal and a non-subintimal recanalization look like? And for those who have never seen a subintimal recanalization, this is what it looks like on video. You can see this is a classic subintimal recanalization of a chronic total occlusion, in this case in the SFA. And I was unable to re-enter the true lumen distally, and so I ended up using a re-entry device. And so these are the types of things you're going to see. So for today's talk, I'm going to focus on 3 main topics related to building a vascular practice in today's environment. Obtaining the referral, you got the referral, now what? And treating the patient. So let's start with obtaining the referral. I think a lot of early practitioners have some difficulty when they're initially building their practice because they feel like they have limited exposure, experience, or training in vascular disease, or they're not comfortable evaluating vascular patients. And you can imagine that this then gives you a lack of overall confidence. Some feel, and I've heard from our vascular fellows over the years, they don't feel like they can talk the talk, so to speak, with referring doctors, including cardiologists, vascular surgeons, podiatrists, etc. And then after that, they say, well, that's why I don't like it. And so I think that, coupled with no training or lectures on how to really build a practice, really makes things difficult. So what can you do? Well, the first thing you can do is learn the disease process. Become an expert not only in vascular disease literature, terminology, etc., but also the various techniques that are needed. And that's the reason why I showed you my vascular channel, to show you that there are things out there on the internet where you can learn a lot of these techniques. Other things you can do are visit experts that are treating a lot of peripheral arterial disease patients. Online, live and recorded cases. Those are very important to start hearing people talk about how they approach various complexities and issues related to vascular disease. Obviously, we talked about YouTube. Talk to industry about their products, because a lot of them will have training programs and sites where you can go and learn about a lot of the things that you need to know. Study the literature about each of the vascular territories, because you have to know the guidelines and understand vascular disease. You have to be an expert at this stuff before you even go out and talk to the first physician or patient about how to send a referral or how to treat them. And remember, this is not easy. It's a lot of work. It's a lot of effort. We're competing with multiple specialties and physicians doing the same thing. And so you have to have a good product, so to speak. So what can you do? Go to the internet. Look up these physicians, whether they're podiatrists, nephrologists, primary care, endocrine and diabetic doctors, wound care centers, etc. Look them up on Google. Look them up on Google Maps. Make a list. See who's around your various treatment sites. And then just start calling them. Set up a breakfast. Talk to their office manager. Say, hey, I want to set up a breakfast, lunch, dinner, or a meeting or a phone call with your physicians to just introduce myself and let them know that I'm one of the new vascular doctors in the area, and I wanted to tell them what I can do for them and for their patients. Remember, present yourself as a vascular expert. Don't just say I'm an interventional radiologist. As we all know, many non-radiologists don't entirely understand what we do. So it's better to present yourself as a vascular expert. Have business cards ready. Indicate that you're a vascular expert in some way on your business card. During the visit, listen and don't sell it too much. Referring doctors will ask you questions when you're there. Just try to be their friend. Try to get to know them. You'll get your opening where they'll ask you certain questions where you can then say, well, this is what I do. This is my expertise. This is where I practice. This is where I work. Make it very clear to them that when they do send a referral or a patient, that you will take care of that patient and send them back. You will not be stealing any of their patients, and you will not be referring them to other experts without discussion with them. That's a very important thing that a lot of referring doctors talk about. And remember, you always want to make sure that you send referral letters and so forth and so on, but we'll talk about that a little bit later. One thing I do want to say, though, is remember that not all podiatrists are the same. Some do very basic podiatry where they're cutting nails in diabetic patients, etc., treating minor wounds. And others are doing, Achilles tendon repairs and very extensive transmetatarsal amputations, etc. So know who your podiatrist is before you even go and talk to them to see if they're even going to have patients to refer to you. Continue to build your reputation as a vascular expert. Know the data, the papers, the guidelines, like I talked about. You can't go into this kind of knowing a little bit about these things. You have to really know all the data as much as possible, know the lingo, be able to talk the talk, and be able to talk to these physicians and patients in a way that shows that you are an expert at what you do. Remember, nobody really cares if you're technically better. Nobody cares if you can get through a CTO better than the next physician down the street. Because what they're really going to be looking at, and I'm talking about the referring physicians, is they're going to be looking at, does this physician answer the phone when I call them, or at least respond very quickly in a timely fashion? Can I get a hold of them 24/7, after hours, on holidays, at night, etc.? And do you do good work? In other words, you have a high success rate, a very low complication rate. And remember, the first 10 cases minimum have to be almost perfect. And that means from the time the patient is referred to you, to the consultation, the treatment, the follow-up, the referral letter, the referral phone call after all this is done. And does the patient, when they go back to their physician, say, this was a phenomenal experience and he or she is a great doctor? So remember, these are the things you have to know. The other thing I wanted to tell you is that when you do go and meet these physicians and are trying to build your referral base and your referral network, remember that a lot of times you'll leave there and you will not be able to tell if it went well or it didn't go well. I've had physicians who have told me that, hey, this is great, I'm going to send you all my patients, and I get 0. And then I have physicians that say nothing. I leave wondering, what happened? Did it go well or not? And then they send me all their patients. So it's something that you won't be able to tell. So just go, do your thing, get out of there, and then maybe do a follow-up at some point based on what's happening. So now, what happens when you get the referral? What do you do at that point? Well, remember, these are things that will really help you in a competitive environment. Once you get that first referral, call the patient yourself. Talk to them, find out what their issue is, and then let them know that your office is going to call them and set up an appointment or a clinic visit as soon as possible. Schedule that consult within 24 hours. Try to get them in as soon as possible. You don't want delays, especially when you're building your practice at the beginning. So, let your office know. Don't schedule these patients weeks or months out. Keep track of these patients. Keep a list someplace, in your system where you will understand kind of where they are throughout the process. Because remember, the bigger the healthcare system, sometimes these patients get lost in the mix and you may lose track of where they are. Did they have the consult? Did they get their non-invasive studies? I don't know. So those are very important things to keep track. Also, prep your office and staff. Make sure that they understand that you want this patient to kind of come in and have a very seamless experience because you're building this referral base with this new physician. After the consult, again, make sure that the non-invasive testing that you need is ordered. Make sure they're scheduled ASAP. Just ordering the tests and saying, okay, see you later, is not the way to do it. You want to make sure that they're actually scheduled. You know when it's going to happen so that when that comes through, you can review it and you can call the patient and the physician and just say, hey, this is what's going on, so on and so forth, and have them come back for their follow-up consultation, whatever your practice pattern is. Remember, you're building your practice, so every part of the process has to be streamlined and go well while you're doing this. To give you an example, all my patients have my cell number after I see them in consultation and after I treat them. And, very few call, I'll be honest with you. They don't want to bother you if they don't have to. Obviously, there are outliers, but in general, it goes well. Always contact the patient with results, discuss their plan either on the phone or in the office, and then obviously schedule them for their treatment if it's appropriate. And remember, the referring doctor, you have to communicate with them. Let them know what's going on during the process. As time goes on, you don't have to be as diligent about calling them after every step of the process because you'll understand how they work and what it is they want from you when you're seeing their patients. But you won't know that until you start interacting with them more frequently. So what do you do now when it comes to actually treating the patient? Remember, again, it's all the standard stuff that we know. Everything has to go well from the time they get to your pre-op area to the treatment to the post-treatment. Make sure you not only talk to them, show them images and pictures, tell them what happened, how it went, and what they can expect, and talk to their family. That is one of the most important things that I try to teach our trainees and fellows is that make sure that you talk to the family of the patient because they're the ones that are also could potentially say really good things or bad things about you when they see the referring physician. And remember, like I said, and I know I'm repeating this, but I think it's very important, the first 10 referrals minimum from a new physician have to go perfect in as many ways as possible. Also, when you're treating these patients, don't take risks. Even if you think you have the skill set to do something very aggressive, try not to at the beginning. If you do your angiogram and you look at the anatomy, you look at the problem at hand, say to yourself, is there something here I can fix easily and then bring them back to do a staged type of intervention? That's something that goes a long way with the patient, the family, and the referring doctor. You can always do an angiogram and say, whoa, this is more than what I expected, and stop. Bring them back a different day. Discuss this with the patient, the family, and and other people that you think are necessary to help you have a successful result. The more comfortable you make the patient, the family, the better off they feel. And you can let the referring doctor know that, hey, we did the angiogram. This looks very complex. It's something I can treat and fix, but we're going to do it staged, and I need to order, additional catheters, equipment, devices, etc., to make sure this goes smooth. They'll love you for this. And here's an example of what I was talking about. This was a physician I had just met. This was the first patient that he sent to me. And you can see this is a very complex fix. It's a long segment, common iliac and external iliac artery CTO. And my initial recanalization was into the proximal SFA. Ultimately, I was able to cross this CTO successfully. And then when I placed my external iliac artery stent and did my post-dilation, you can see I had a localized perforation, which then I had to manage and treat this as well. Ultimately, I was able to achieve an excellent angiographic and clinical outcome with an excellent result, as you can see here. And the patient, the family, and the referring doctors were all very happy. But you can see this was a first-time referral, first-time case from this doctor, and it was very complex. Here's another example of the exact same thing, where as a doctor I just met, first-time referral where they sent me a patient who had a large area of ulceration that hadn't been healing over the course of about 12 months. And you can see on the initial angiogram where I had antegrade access, we've got occlusion of the anterior tibial artery at its origin, the TP artery trunk, there's some reconstitution of the distal posterior tibial artery above the ankle joint, and there's really not much below the ankle. So now I'm dealing with, again, a first-time referral, tough case, with below knee and below ankle disease, and I knew I had to have a successful result to make sure that this referring doctor would want to send to me, because now is where you get to show your skill set. This is obviously a tough recanalization. It required antegrade and retrograde access. You can see on the videos here that on the far left, I'm in two different subintimal planes. Ultimately, using Navi bossing and some other techniques, I was able to get through and through access, perform orbital atherectomy in this case. As you can see here, there's the channel is open, so I'm getting a little bit of blood that's dripping out the sheath, which is open. It also allows debris to clear, and then I was ultimately able to achieve a nice 2-vessel recanalization and runoff, and a nice angiographic wound blush, as you can see in that image to the far right. And over the course of about 12 months, we were able to achieve significant healing, obviously with good podiatry care and so forth. So let's talk about some other things that I think that are very important. I think for those of us who are familiar with endo-AVF, if you're not, I would recommend looking into this. This is where you're creating a dialysis fistula percutaneously. There's obviously 2 companies that do this, but this is another source of referral that you can get from your nephrologist and so forth. And when you get these referrals, remember, these are patients with oftentimes diabetes in addition to CKD, and they are obviously going to be patients with peripheral arterial disease. They may have venous disease, etc. And so by getting the referral for the endo-AVF, now you have a referral for a lot of other issues that these patients may have over the course of their lifetime. And so this is another way to build your referral base for vascular patients. I think another thing that's important is if you're able to, at some point as you get busier, try to convince your group, your practice, your partners, etc. about obtaining a PVR ABI machine. Most radiology labs will have duplex arterial ultrasound, so that typically is not an issue. That way you can scan your patients either in your clinic or the same day, which really helps for patient satisfaction and throughput and so forth. Remember, PAD patients usually get referred to you from somebody, either a family member or somebody that knows somebody that has PAD, or from a referring physician, as we all know, or even wound care centers. Less commonly is a patient who sees a website and then says, oh, let me call this doctor. That tends to be more common for patients that have fibroid disease or enlarged prostate glands, as in UFEs and PAE. If you're able to and you have the time, learn wound care. See patients at a local wound care center. That can help you. I don't do that. I'm busy enough at this point that I don't have the time, but it is another thing that can help you in terms of building your referral base for vascular patients. Remember, citywide, countywide screening programs for the American Diabetes Association, American Kidney Association, etc. They have them 2-3 times, maybe 4 times a year. Get involved, have a booth, see patients that way. That's something that can help you tremendously in terms of building your practice. I think vascular medicine is the key. Also, make sure you understand how to treat these patients in terms of medical management after a fix, or in cases where you don't need a fix. That'll go a long way in terms of showing your expertise. And again, it can't be said enough. Know the current vascular guidelines. These are published by the American College of Cardiology, SIR, Society of Vascular Surgery, both in the US and Europe and Asia, etc. Understand them. Know what the guidelines tell you in terms of evaluating and diagnosing and treating these patients. So I thought before I end this talk that I would do a little bit of teaching before we start our Q&A session. So quickly, let's talk about the pedal-plantar loop. If you're not familiar with it, it's basically a loop formed by the dorsalis pedis artery, which gives a branch called the communicating artery or perforating artery, which then crosses the foot and anastomoses with the lateral plantar artery and then comes back to the posterior tibial artery. And really the important anatomic landmark is the base of the first metatarsal, as you can see here with the red arrow. And here's that loop. Again, dorsalis pedis artery to the communicating or deep perforating artery, lateral plantar artery, back to the posterior tibial artery. So that's the classic pedal-plantar loop if you're not familiar with it. Another loop that's very important is formed by the arcuate artery of the foot. Again, it's a branch of the dorsalis pedis artery, And you can see here it comes off more proximal than the communicating or deep perforating artery of the pedal-plantar loop. It crosses the foot anastomosis with the lateral tarsal artery to again form another important loop below the ankle joint. In this case, it's only present 17% of the time. And this is what these loops look like. Again, here's the pedal-plantar loop, the loop form of the arcuate artery, two very important loops that are important in terms of outflow of the foot when performing vascular interventions. Remember, there are pedal loop variations, so everything is not like a netter, a manual, or a textbook like you would expect, and so being aware that there are anatomic variations is very important. So to kind of drive this point home, let's look at a real case. Here's a patient with non-healing toe ulcerations and a lateral foot angiogram which shows you occlusion of the distal dorsalis pedis artery and a portion of the anterior aspect of the pedal-plantar loop. I put a normal AP angiogram in the middle. This is from Marco Manzi's article in 2011. It's a great article if you haven't read it. And I put this here because I wanted to show you what the pedal-plantar loop looks like in the AP view, and that's it there. In addition, I'm also including a video during this case to show you what it looks like when you're recanalizing a pedal-plantar loop in someone who has classic anatomy. I want to focus you on where the red arrow is because that's a key anatomic landmark between the base and the first metatarsal, as that's where the branch or the turn of the pedal-plantar loop occurs from the dorsalis pedis artery into the communicating artery or the deep perforating artery of the pedal-plantar loop. And I want you to notice the subtle prolapse of the guide wire. That is a tip-off that is a branch point there. And so that should kind of clue you into that's where you're going to be taking your first turn into the pedal-plantar loop from the dorsalis pedis artery. And then at about the base of the third or fourth metatarsal, depending on the obliquity of your AP projection, the next turn of the pedal-plantar loop should take place into the lateral plantar artery and ultimately into the posterior tibial artery. So that's a classic pedal-plantar loop recanalization in somebody who has classic anatomy. Obviously, once we get through, we want to make sure that we're intraluminal by injecting contrast. In this case, I performed vessel prep with orbital atherectomy, followed by prolonged low-pressure angioplasty, and was ultimately able to achieve a nice angiographic and clinical result in this patient with healing of their toe ulcerations. And the referring doctor and patient and family were all very happy. Thank you.